Good morning and welcome to this meeting of the Physician-Focused Payment Model Technical Advisory Committee, known as PTAC. I'm Jeff Baylett, the chair of PTAC, and as you may know, PTAC has been looking across its portfolio to explore themes that have spanned several past proposals. Today, we will dive into the topic of care coordination, and our next theme-based discussion will examine how efforts to address equity and the social determinants of health can be optimized in the context with alternative payment models and physician-focused payment models. But first, at this time, we are honored to be joined by a member of leadership at the Centers of Medicare and Medicaid Services. I'm excited to introduce Dr. Liz Fowler, who serves as the CMS Deputy Administrator and the CMS Innovation Center Director. Before joining CMS earlier this year, she was the Executive Vice President of Programs at the Commonwealth Fund. She brings with her an extensive health policy experience, having also served as Vice President for Global Health Policy at Johnson & Johnson, as well as the Chief Health Counsel to a former Senate Finance Committee Chair. And with that, it is my pleasure to welcome Dr. Fowler.
Dr. Baylett, thank you so much for that introduction, and thank you to all the members of the Physician-Focused Payment Model Technical Advisory Committee, or PTAC. I really appreciate the invitation, and we might not be meeting in the Great Hall of the Humphrey Building, but I really appreciate that you and your committee have continued its important work despite COVID and the public health emergency. And I'm delighted to be here, and I'm pleased to have this opportunity to introduce myself. It's been just over 3 months since I became director of the CMS Innovation Center, and I'm really fortunate to have this role. I've been learning more about the PTAC from my team and from stakeholders across the board. This is my third time working for CMS, and I have a deep appreciation for the agency, the team, and its powerful mission. And I extend that same appreciation for our colleagues at ASPE, who coordinate the PTAC. And as many of you know, Administrator Chiquita Brooks-LaSure, our new boss at CMS, also previously served at the Department of Health and Human Services, first as Director of Coverage Policy in the Office of Health Reform, and then as Deputy Center and Policy Director for the Center for Consumer Information and Insurance Oversight, or CISIO. Together, our experience at HHS and CMS will be beneficial during this critical time for our healthcare system. And I want to explain why. I really believe that we are at a crossroads in value-based care. We have been clearing a path to move the system toward value and away from volume, now with 10 years of experience. And the path is not necessarily straightforward. We've lost a bit of focus in some respects, and we need to continue taking the steps to move the system towards value-based care. At this critical juncture, it's a good time to take stock of where we are and where we go next. And in the very short time I have with you, I want to touch base on the role that CMS has in setting a direction for value-based care, including how health equity fits in, and what part I see specifically for the CMS Innovation Center and how PTAC can contribute to this story. Over the past few months, CMS, the Innovation Center, has undertaken a strategic review and refresh based on the 10 years of lessons learned in order to reestablish a shared vision of the health system we're driving toward. And what's been most apparent from all the input we've received and all the literature and all the recommendations we've reviewed is that patients should be at the center of that system. So what does that mean? It means the health system of the future must meet patients where they are, delivering care in homes and communities in the least restrictive and most accessible setting possible. Most likely it also means more virtual care. And we've all seen the benefits of telehealth during the public health emergency. And thank you for PTAC's work in this area. I think it's really been an important contribution. It must deliver high quality, accessible care that focuses on keeping patients healthy, coordinate care seamlessly across settings and providers enabled by data and technology that includes appropriate referrals, management, and payment for specialty care. Holistically addresses patients' needs, including behavioral health and social determinants, and achieves equitable outcomes through high-quality, person-centered care for all. In our mind, it means that every Medicare and Medicaid beneficiary is in a care relationship that includes meaningful accountability for quality and total cost of care, and that quality measures align with goals that matter to patients and align with patients' values, like reducing mortality and improving functional status so that patients can keep up with loved ones. Achieving this vision is going to require us all to think about bringing high-quality, value-based care to every community in America. By advancing a continuum of total cost of care models to engage providers, we need to fix some of the biggest payment issues today so that we're moving forward with value-based care on a stronger foundation. This includes addressing issues in fee-for-service, like prescription drug pricing, as well as targeted initiatives to address populations that are not well served by the current program, overuse of low-value care, underuse of needed care. And we need to align across payers and across all stakeholder groups to facilitate patient-centered transformation at the level of both individual providers and regional systems. Changing Medicare fee-for-service isn't enough. At a minimum, Medicare and Medicaid payment models must be more aligned and focused on improved health and equitable outcomes for patients. This means we have to focus on equity in everything we do. Within the department, as we consider policy priorities, proposals, and payment and service delivery models, a very clear signal has been sent that everything we do needs to be viewed through an equity lens. Excuse me. Achieving our goals and making progress in advancing health equity will take all of us working together. Excuse me. Federal, state, local, tribal organizations, healthcare providers, plans, individuals, families, policymakers, and other stakeholders. This brings me to PTAC's value, and specifically the thoughtful way that the committee rigorously and vigorously reviews the proposals submitted by individuals and other stakeholders, the recent roundtable discussions on telehealth, and today's topic of care coordination as well. We welcome PTAC's comments and review as we forge our path and continue our journey towards healthcare transformation and delivering and implementing payment and healthcare delivery models that test and define first, healthcare equity. Payers, providers, purchasers, and other stakeholders in the system may have different responses in addressing health equity, but we should adopt common definitions. The role and importance of data, collecting data, measuring impact, and reporting out what matters a lot, but there's a lack of uniformity in data collection and analytic standards, which adds to the challenges of data sharing. And third, the role of payment design. CMMI tests payment and service delivery models. Our mission is for America to have the highest quality and most affordable healthcare system in the world. We know we're not there yet. So the PTAC process allows for a unique opportunity to identify strategies and solutions to achieve value-based care in the health system. I sincerely hope we can keep these public discussions going as advancing health equity takes off as a national priority, and we continue to develop future payment and service delivery models. And with that, I'll conclude and turn it over to Jeff. Thank you again for your time, and thanks to all members for pulling together this public session and for your dedication to healthcare transformation. Thanks a lot, Jeff.
Thank you, Liz, for joining us to provide those remarks. And we really look forward to continuing to work with you and your team. Because of the coronavirus pandemic, as you said, we're holding this meeting virtually rather than gathering in the Great Hall of the Humphrey Building. We aim to provide a seamless virtual experience as close to an in-person PTAC meeting as possible. That said, we appreciate your understanding in advance if any technical challenges arise, such as sound delays or background noise. If you have any technical questions, please email our contractor team at ptacregistration@norc.org. Again, that's PTAC registration@norc.org. If you've joined us by WebEx, you can also message the meeting host with any questions. Many PTAC stakeholders are directly involved in responding to the pandemic, and we are thankful for your service to our country. We want to thank providers, support staff, caregivers, family members, and others who are supporting patients during the pandemic. We recognize that it's a privilege to have you joining us today. Throughout the committee's tenure of reviewing the proposals we have received, we have noted common themes that have emerged across multiple proposals from a variety of stakeholders. As part of our last two public meetings, we explored the theme of telehealth in the context of alternative payment models, resulting in a report to the Secretary on telehealth that we released earlier this week. Today, we will explore a second theme that has spanned several past proposals, the role that care coordination can play in optimizing healthcare delivery and value-based transformation in the context of alternative payment models and physician-focused payment models. We have a great lineup planned, but first, I'd like to provide some updates on the committee's work since our last public meeting in December. We have worked hard to support stakeholders who may be interested in submitting proposals to PTAC. In April, we released our updated proposal submission instructions. Our main goal with the updates is to make it easier for stakeholders to submit proposals. We developed a new second track for proposal review to provide additional flexibility for those who have important care delivery, payment, or policy issues to raise, but may have varying degrees of resources available as they develop their proposed models. Aligned with our interest in providing resources for those who are developing payment models, we also released a reference guide on common APM approaches. That may be particularly useful for those who like to explore some potential payment methodologies that may be appropriate for their care delivery model, and you can find that guide on the resource page of the ASPE PTAC website. As a reminder, PTAC accepts proposals on a rolling basis. The committee does not have any proposals to review at this time, but know that we remain ready to review proposals as they come in and are eager to engage with stakeholders who want to propose models for our review and comment. As the new administration gets underway, we want to encourage the field to develop models and send them to the committee. This is a great time for new models to come in from the field for consideration by PTAC, and then for the committee to share our comments and recommendations with the new Secretary of HHS. We have a lot prepared for today. First, several committee members who volunteered to assist in preparing for today's theme-based discussion will provide an overview that will help to provide some context. They have done a lot of prep work for today, including working with staff on an environmental scan that is available on the ASPE PTAC website. Then our first panel, which is composed of several subject matter experts, will provide a wide range of perspectives on care coordination and alternative payment models. After a short break, we will have a panel of previous submitters, guests representing organizations that have submitted proposals to PTAC that included care coordination components. This is not a redeliberation of their proposals, but a special opportunity to take a deeper dive into the topic and learn more from the field about the relationship between care coordination and alternative payment models. Next, we will have a public comment period to hear additional input and perspectives on care coordination. Comments will be limited to 3 minutes each to maximize the number of participants. If you have not registered in advance to give an oral public comment but would like to, please email ptacregistration@norc.org. Again, that's ptacregistration@norc.org. After we hear from public commenters, the committee will discuss what we have learned, shape our comments for the Secretary of HHS, and share any closing thoughts on the day's events. Finally, at the end of the day, we will announce a request for input to hear from others who would like to provide information on care coordination as it relates to APMs. Taken together, the preparatory work and the online materials, the panel discussions, and the public comments are aimed at informing PTAC about the most current knowledge from the field about how to optimize care coordination and further the goal of value-based care through in the context of alternative payment models. At this time, I would like PTAC members to please introduce themselves. Please share your name, your organization, and if you'd like, feel free to share a brief word about any experiences you have with care coordination, today's topic. Because our meeting is virtual, I'll cue each of you, starting with myself. I'm Jeff Bailett, the CEO of Alteus, a physician enablement organization, and I am an ENT surgeon by training. Paul, you're next as the vice chair.
Thanks, Jeff. Paul Casal, I'm a cardiologist. I lead population health at New York Presbyterian, Weill Cornell, and Columbia University. And in that role, I lead a MSSP ACO, and care coordination fits prominently in our work.
Thank you, Paul. Carrie.
Thanks, Jeff. Carrie Kalla. I'm a health economist and a professor at the Dartmouth Institute for Health Policy and Clinical Practice. And my interaction with care coordination is largely both quantitative and qualitative research on providers participating in alternative payment models and what they do around care coordination. Thanks.
Great. Thanks, Carrie. Jay?
I'm Jay Phelps. I am the president and CEO of Philadelphia College of Osteopathic Medicine. In my previous life with a health insurer, I was responsible for care coordination and case management and managed Medicaid plan across 5 states.
Thank you, Jay. Lauren?
Good morning, I'm Lauren Hardin. I'm Senior Advisor for the National Center for Complex Health and Social Needs. I spend the majority of my time with sites, communities, states, government, designing models for complex populations, and have spent the last 20 years leading and designing care coordination for every kind of model, ranging from children's hospice, palliative care, every kind of ACO, BPCI, and now community-based cross-sector collaboratives.
Thank you, Lauren. Josh?
Good morning, everybody. Josh Lau here, internal medicine physician at the University of Washington in Seattle. I think about care coordination in 2 roles. The first is through research, studying the impact of payment and delivery models. And the second is through a role that I have as an enterprise medical director for payment strategy, through which I work with our value-based care team in our integrated delivery network to think about care coordination in several programs.
Great. Lee?
Good morning. I'm Terry Lee Mills. I'm a family physician, and I'm currently Senior Vice President and Chief Medical Officer at Community Care of Oklahoma, a regional provider-owned health plan. I've come at care coordination from both medical group leadership and on the health plan side, from building care coordination at an individual practice level all the way scaled up to an enterprise level.
Thanks, Lee. Vita?
Hi, Savita Patel. I'm an internal medicine physician in DC, and my role in care coordination, I lead primary care doctors in the DMV area for specifically kind of safety net post-COVID around transitioning to at-home and remote-based care where appropriate. Thank you.
Thanks, Gavita. Bruce?
I'm Bruce Steinwald. I'm a health economist here in Washington, D.C. My experience with care coordination is the lack of coordination of the care that I've received over the past several years.
Thank you, Bruce. And Jennifer?
Hi, I'm Jennifer Weiler, emergency physician by training, professor of medicine, and I'm the Chief Quality Officer for DC Health in Denver. I'm also a co-founder of our Care Innovation Center, where we partner with digital health companies to think about how to optimize care delivery, including care coordination and leveraging digital technologies. My additional experience with care coordination is one is a practicing physician in the emergency department, also from various operational leadership roles, and I was principal investigator on a citywide grant looking at emergency department high utilizers, where we were able to partner with community organizations and improve health outcomes for patients.
Thank you. Thank you all. At this time, let's move to our initial presentation. 3 PTAC committee members have served on the Care Coordination Preliminary Comments Development Team, or PCDT, that have worked closely with staff to prepare for this meeting. I'm thankful for the hard work that they put into organizing today's discussions. And we'll begin with a presentation on some findings from an environmental scan on care coordination and alternative payment models that is also available on the ASPE PTAC website. PTAC members, you'll have an opportunity to ask the PCTD any follow-up questions afterward. At this time, I'm going to turn it over to the PCTD DT lead, and that's Lee. Lee?
Thank you, Mr. Chair. Happy to present this series of slides, 17 in number, just to set the context of what the preliminary comment development team and with staff's invaluable help has learned about prior PTAC proposals, and then a comprehensive environmental surveillance of what really is known versus guessed in the research. And certainly want to thank and call out the the rest of the team, Lauren Harden and Dr. Angela Sinopoli, who have invested innumerable hours over the last 4 months in this work. So take next slide, please. So just as way as introduction, this is to set the context of our conception of care coordination, a topic that I think everybody on the call is familiar with in various ways, that holds both incredible promise and importance for individual patients, all the way up to the stake of the healthcare system and ecology in total. From 2020 to 2016, PTAC received 35 stakeholder-submitted proposed physician-focused payment models and voted and deliberated on 28 of those to see which of them really met the Secretary's criteria number 10, or sorry, the criteria is 10 criteria, which includes criteria 7, which is all about integration and care coordination. And that's defined as the degree to which the proposal encouraged greater integration and care coordination among practitioners and across settings, where multiple practitioners or settings are relevant to delivering care to the population treated. We found that one of those 28 met and deserved priority consideration for meeting that criteria. 15 met the criteria, 10 did not, and 2 proposed models, the criteria wasn't applicable. Next slide. In reviewing these, it becomes evident and is aware that there's a definitional problem, and that there really is no consensus on the definition of care coordination. Care coordination, often has a functional definition that varies from the beholder and the context. For the work in framing what we know about care coordination, PTAC is using the working definition from AHRQ as a starting point of conversation, which is that care coordination involves deliberately organizing patient care activities and sharing information among all the participants concerned with the patient's care to achieve safer and more effective care. That means that the patient's needs and preferences are known ahead of time, communicated at the right time to the right people, and that the information is used to provide safe, appropriate, and effective care to the patient. Next slide. So another thing that became really evident in working through that is that there are multiple contexts in which care coordination can occur, often operating simultaneously in different proposed models. So these contexts are really 3 or 4 in number, and one is care coordination for population health, meaning general coordination of all patients regardless of need. Often that's a whole community, whole geography, a population health perspective. Then there's care coordination for specific populations, typically focusing on individuals with a certain named condition, chronic disease, or a certain vulnerability. Interacting simultaneously with both of those contexts is care coordination around acute event, including transitions. And this is especially true for the interactions between emergency department and acute care to post-acute care, et cetera. And then wrapped around all of that, if you will, is the context of health-related social needs and social determinants of health, acting simultaneously in all those contexts. Next slide. At the same time, there's some domains associated with care coordination. It certainly involves a wide range of functions and activities. Again, not 100% concurrence about which are more important or important, and we would all have a spirited discussion about the pieces of functions and activities that we found most valuable in our work settings. But there are some functional domains considered key that AHRQ has identified, and these include establishing accountability and negotiating responsibility for coordination, clear communication, facilitating transitions in sites of care, accessing patient-centered needs and goals, creating a proactive plan of care with patient input, monitoring, following up, and responding to changes in the patient situation or context or needs, support self-management goals, linking the community resources, and then aligning those resources with patients and population needs. Next slide. So in all these domains, again, multiple activities of importance, and we could list many more, but PCDT identified these following activities as seeming to be particularly important in optimizing patient-centered and focused care coordination in the context of APMs. And that includes using care coordinators, named individual people with their responsibility, care coordinating of treatment and care activities across settings, providers, and sectors, behavioral health management, the timely sharing of necessary information across providers of care, the documentation of patients' needs and preferences, and turning that into essentially a living document that helps guide the whole care team, and then use of shared decision-making, as well as ongoing evidence about the effectiveness of interventions in care to create a proactive plan structured to address patients' needs. We acknowledge that strategies also, and there's a tremendous amount of energy spent around structural change, such as financial management and planning across operational units. PTAC is particularly focused on strategies for improving the clinical aspects of care coordination in the context of APMs and value-based transformation. Next slide. So in thinking through that context, we did want to then analyze and look at the proposals that have been submitted and try to pull out themes that rise to the top. Go ahead. So first of all, of the proposals that were found to meet criteria 7 about integration and care coordination, we did find that the proposals, the clinical or the coordination aspects varied by clinical focus, clinical setting of care, and the context of the care coordination. So some were focused on specific health conditions or diseases, serious illnesses a bucket, and other variety of special conditions. Some were focused on clinical settings, including primary care, patient's home, skilled nursing facilities, transitions of care, and rural providers. And then lastly, just the overall context of that care coordination, whether it was a population-wide management consideration, whether it was specific, more focused populations, yet not focused on a specific condition, or whether it was related to acute events. Often, most of the proposals focused on only one of those, but it's certainly conceptual that a proposal or a successful coordination plan could focus on multiple of those at the same time. Next slide. So we also noticed that there were some commonalities among the care coordination functions and activities that were included in proposals that were found to meet. Most proposals did indeed address at least one care coordination function. That's pretty foundational. The common functions or activities that were emphasized in models included establishing accountability or negotiating responsibility, facilitating transitions and coordination across settings, communication and streamlining, improving communication and timeliness, and then finally assessing patients' needs and goals, such as documenting needs and use of a patient-centered care plan, etc. Less commonly, some proposals emphasized a care plan itself, aligning resources with patient and population needs, such as through a risk stratification process, and supporting self-management goals, including shared decision-making and systematized high-quality education. Next slides. In summary, kind of looking at the proposals we received that met criteria 7, there were some common strengths among those proposals and some common gaps. For those that met, common strengths were that the proposals outlined a clear process for coordination, outlined explicit data sharing mechanisms, had a clear framework for patient engagement, had defined performance quality metrics around care coordination, emphasized payment mechanisms for addressing care delivery objectives and emphasizing care coordination, had engagement standards for and among primary care providers and specialists, emphasized multidisciplinary teams, paid close attention to continuity of care and those healing relationships, and then involved in some fashion a bundled episode payment or capitated model. So those were the strengths of the proposals found to meet criteria 7. There were some common gaps in the proposals found to not meet criteria number 7, which included unclear specifications or requirements. It included a lack of clear accountability. included lack of interoperability of EHRs or data sharing, included lack of guidance or mechanisms about that data sharing, inaccessibility related to proprietary software, lack of specific quality metrics around care coordination, and concerns about scalability of a proposed model. Next slide. And then finally, with the staff's invaluable work, done a comprehensive environmental scan, and certain highlights of that learnings have risen to the top that we wanted to highlight to frame our discussion for today among our expert panels. Next slide. The first is that there are some key findings on recent initiatives in care coordination related to payment. And these findings include that Medicare has introduced both through G-code and through CPT processes some billing codes to reimburse providers for care coordination among fee-for-service beneficiaries. And this includes the TCM codes in 2013 and a variety of chronic care management codes since 2015. We had a finding that APMs can reimburse providers for care coordination, and that's commonly done. You see that widely in state Medicaid programs that have transitioned more towards capitated payments with risk-sharing organizations and primary care case management. You also see some states focusing on care coordination and building payment mechanisms in dual eligible population. Additionally, CMMI has designed and launched numerous APMs in Medicare fee-for-service that includes mechanisms to support care coordination. So there are certainly a wide variety of models that include population-based and performance-based payments, one-time or upfront funding, care management fees, capitation, and fee-for-service-based payments around care coordination and quality. And then finally, health plans have had a wide variety of activity across public and private payers to adopt programs to support care coordination, including PCMH programs, capitation arrangements, and other value-based models that support coordination. Next slide. Another finding is that performance metrics are important and have a wide variety of strengths and weaknesses. We found that there's a number of challenges in isolating and measuring the effects of care coordination. That's both, a wide variety of metrics that are wholly dependent on the context and the situation, as well as for things that may use the same metric, different definitions. There are certainly reported barriers, including variation in whether and how care coordination is documented, whether it's in claims or EHRs, and then challenges in measuring care coordination using that electronic data. Often care coordination is as much a qualitative as a quantitative engagement. Many of the available measures focus more on outcomes to avoid, such as hospitalizations and readmissions, rather than the outcomes to be achieved. Some CMMI models measure caregiver and beneficiary satisfaction or practice level process measures. Others of the models proposed to PTAC included direct process measures related to the activity of care coordination, such as number of completed health plans, number of transitions, coordinated, et cetera, while other proposed models use measures of cost, utilization, and quality as basically proxies for coordination events that may or may not be directly related. So plenty of metric challenges in defining, measuring, and then using metrics. Next slide. We did find in the environmental scan that there is some relationships between selected assumptions and the available evidence. So there are some assumptions that we see working in models about patients who are likely to benefit from care coordination, then with a positive impact on cost or utilization. And that boils down to two populations. That a working assumption is that patients are more amenable to care coordination that will be effective if they have modifiable risk factors or risk factors in an individual patient or team control, and or if the care coordination activity is focused on users of healthcare services, including those with chronic conditions. The available evidence regarding the effects of care coordination is quite mixed. Some studies show certain care coordination functions do have positive impact on utilizations, including outcomes, targeting the high-cost patients, facilitating care physicians and primary care population-wide coordination. There certainly are opportunities to improve care while reducing costs through coordinating care for high-cost patients. There are some promising findings that exist related to reducing the spend for post-acute care when those transitions and contexts are better coordinated. And APMs have shown promise in improving specific performance metrics when that APM creates an incentive for care coordination focused at that metric. So there is evidence in the literature about positive effects of care coordination, but not any evidence that's dominant or overbearing at this point. Next slide. The impact of the public health emergency that we've all experienced over the last 15 months has certainly had an impact on care coordination. Care coordination itself, when established, helped mitigate many of the challenges associated with public health emergency, enabling providers to proactively reach out to patients and care for the patients that were not coming to the office, removing barriers to access, including transportation, and facilitating communication among providers and patients. The temporary changes in billing requirements under the Section 1135 waiver authority was tremendously beneficial and has created a rapid burst of innovation. It's been fun and exciting to watch. At the same time, the increased reliance on telehealth activity for some providers has posed challenges. This particularly includes smaller practices or long-term care facilities that may not have the necessary infrastructure to be able to transition to virtual care or care coordination. Additionally, the public health emergency has brought to the light or surfaced even more so than previously known disparities in access to care coordination. It's become harder for some patients to engage in healthcare due to competing priorities, especially in low-income and rural communities and those with social isolation. Next slide. Care coordination in behavioral health is another important theme that's come out of the literature, environmental surveillance. So we certainly are aware, most of us at a very granular level, as well as in the literature, that there's a shortage of behavioral health providers, which poses an ongoing dramatic challenge in coordinating physical and mental health care. CMMI models that incorporate behavioral health services exist, including CPC Plus and the Pioneer ACO. The PTAC did receive a proposed model from the AFP that highly emphasized behavioral health services and integration. We did find that the financial alignment incentive integrates primary care, acute care, behavioral health, and LTSS among dual eligible enrollees, and Medicaid has other initiatives also focusing or incorporating behavioral health into care coordination, which seems to be a critically important theme for all of us moving forward. Finally, the American Rescue Plan includes funding for addressing behavioral health needs and encourages grantees to coordinate among local entities and providers. Next slide. Finally, it's evident to all of us, I know, that there are many areas where additional information and research is going to be needed. And this includes, in the PTAC's mind, what activities can help optimize care coordination in APMs and PFPMs to improve quality or reduce cost? What types of payment models are likely to incentivize care coordination, including specific functions? How do care coordination functions that we've mentioned vary by context, population, a patient characteristic, or a geographic region? How has care coordination evolved over the last year through the public health emergency and with increased attention on the priority of achieving health equity and addressing social determinants of health? What are the best ways to measure the quality and effectiveness of care coordination? And what is the best time frame for assessing the benefits and the costs of care coordination? And lastly, what types of information or descriptions of care coordination are needed to facilitate the PTAC evaluation of proposals that we receive? And next slide. I believe that's the end. We have additional details in the appendix, including further detailed analysis of the care coordination components of proposed models that the PTAC has reviewed. And then the environmental A scan of the literature is also available. I again want to thank the other members, Lauren Harden and Angela Sinopoli of the PTAC, for their invaluable work over the last several months putting this together. Mr. Chair, I'll pass it back to you.
Thank you, Lee, for that comprehensive presentation and summary. Lauren, before I turn it over to the full PTAC, did you have any comments you'd like to make?
I just wanted to say Lee covered it very well. I think we have a tremendous opportunity to take the lessons we've learned during the pandemic about the vulnerability of our communities, what can happen when we come together across sectors and also interprofessionally to really address care delivery from the perspective of what patients and families need in their homes and in their communities. So there's tremendous opportunity for the next level of innovation and model development to inform the objectives and priorities of the new administration, as Dr. Fowler laid out.
Great. Thank you, Lauren. Thank you, Lee. And I also want to thank Angelo, who's unable to join us today, but he was a significant participant in the PCDT. Again, very helpful background for our discussion today. I'll turn it over to the committee members to ask questions of the PCDT at this time, if there are any questions.
Hey, Jeff. It's Jay.
Yeah. Hey, Jay. Go ahead.
Yeah, I have a question, Lee. In either your environmental scan or going over, the highlights of the previous submitters, did you see anything significant from a technology standpoint? Because, historically, a lot of care coordination, case management, it's been labor intensive. Did you come across anything how, either ACOs or individual practices or plans, anything from a technology standpoint that stood out from your perspective?
Well, I certainly look forward to invite Lauren's comments as well. But I think what we've seen in environmental surveillance, as well as just practical experience for most of us, is that technology and communication is either the great enabler or the existential barrier that can't be gotten past. So I would say that using technology to emphasize timely, if not instantaneous communication among the members of a care team involved in coordination is a necessary but not wholly sufficient task. So it's something that has to be taken care of and dealt with and enabled to even start the process of care coordination that's going to be effective.
I agree with Lee's comments. I think just in addition, there's been a tremendous growth in obviously telehealth. So on the positive side of that, have been a lot less no-shows for behavioral health for different visits because of the ease of access. There's been a great growth in resource platforms like Unite Us and NowPow and other technology coming into communities to gather what are the social determinant of health resources in the community-based organizations and how can that be shared across the community to accelerate care coordination. And then there's been growth in development of platforms for shared plans of care. So some of those things have not landed in the literature yet because they're growing now and the studies haven't been done, but that's what we're seeing on the ground, as well as a lot more AI sort of virtual behavioral health type platforms moving forward.
Thanks.
Bruce, you had a question?
Yeah, I do. My mother-in-law lived with us for 18 years before she passed away at age 100. And she had multiple chronic illnesses, and we were determined to keep her here at home. Even though my wife and I have some expertise in the healthcare field, we were unable to coordinate her care ourselves. And we hired a navigator to help us do that. And actually, it turned out to be a good move. She was very capable. So my question is, have you run into, or in the environmental scan or any of your research, did you single out the role of navigators in helping to, if not coordinate the care, at least help people figure out how to do it or where to get it?
you want me to answer first, please? So, again, one of the challenges in this area is how much evidence has actually landed in the literature. So let's talk about practice. I think that there's a tremendous need for longitudinal and cross-sector care management, and that's what you're seeing with a navigator. The person isn't only navigating and helping you with the cardiac disease under an ACO and then it ends when the episode of payment for care coordination ends. They're looking holistically at your mother-in-law and your family. What are the needs and what are the cross-sector coordination components that are needed? On the ground, that's what's moving forward and that's what's working for people. The evidence around that is still emerging, but longitudinal versus episodic care management, I think, is really key in the future, and also the ability to deeply develop a holistic, trusting relationship with the entire family to look across systems. So from the patient and family perspective, that's what we all want, is that holistic view and someone who will navigate regardless of payer source, regardless of hospital system, community-based organization, someone who can see that whole picture. But I think there's a tremendous opportunity for more research and evidence in that area.
Thank you, Lauren. My impression is that the good navigators are kind of hard to find. It took us a while, and I wondered if that's generally the case.
It really depends on the part of the country, and when you think about what is the payment source for that, and then there are models, so palliative care and hospice care is probably the closest to that, an interprofessional team that navigates regardless of setting. But not everyone is in the palliative care or hospice continuum. And many people with multiple chronic conditions could benefit from that holistic approach that's longitudinal in developing a relationship.
Yeah, I agree with Lauren's comments as well, Bruce, and your family situation that I've experienced as well. I think part of that speaks to the concept of establishing accountability and negotiating clear responsibility and communication patterns for coordination at a very granular, family patient focused level. I think to some degree, needing a navigator is, I hope and pray,
We lost you, Terry.
I hope and pray that needing an individual as a navigator to help manage the complexity of communication is a transitional state as we move towards, as Lauren said, it's more of an ongoing healing continual relationship where the providers and the care team with the patients that are focused are continually in communication, much like you manage your family relationships with endless text and instant messaging. It's not the episodic place a phone call as a single event, and that's going to take continued work and continued research to get there.
Great.
Thank you, guys.
Josh, you had a question, comment?
I did. Thanks for this, Lauren and Terry and Angelo. I was really struck by kind of the how you categorize the different settings, clinical populations, context, and also resonated with you about this idea of where data are limited. I know you set up a number of questions about what we'd love in terms of more information. I'm curious if you combine those. Any sense from the environmental scan about, we see mixed evidence. Where is the evidence the most positive and what's the most, maybe the least positive when we map it onto kind of categorization you guys used to inform next steps?
Well, great question, Josh. My understanding of the literature and seasoned with personal experience is that it seems like the best effectiveness, actually changing quality outcomes and costs, seems to be centered in the context of very high cost disease-based intensive coordination or navigation, and at the other end of the spectrum, truly advanced whole population, usually primary care focused coordination of just whole family and community needs. In a sense, it's at two ends of the spectrum, although that may not be the right way to conceive of it. But those are what I've seen both in literature and playing out in real life. Lauren?
I would support that. And I would also just add there's a lot of missing evidence about the value proposition for really what do patients and families define as value, and how does that translate into evidence around what we should be focused on. So as Dr. Fowler was talking about functional status, quality of life, trust, safety, being seen and heard, many of those things we don't put the same financial value on. And so the evidence is highly focused on costs and utilization, which is good. We want to reduce costs. But what is the value in that equation of addressing equity, addressing some of the other patient and family value quality issues, and how can we translate that into a new value equation? I think is what I was left with looking at the literature.
Thanks.
And Jeff, can I just add on to that, just for,
Yes.
it's sort of a comment and a question, but, I noticed, on the key functional domains, the use of care coordinators was at the top. And, I think it just emphasizes that, coordination sort of doesn't occur necessarily organically, and it really does require investment. And Lauren, to your point, I'm wondering, as you looked at the environmental scan, many times we look at the return on investment, and that's why we end up looking at ED and hospitalizations, because you can assign dollars to that. But in fact, what you just described is not only equally, but more important. But I think it's to the points that Lee made in the slides, that I don't think we quantify that very well. And so when we need to sort of put in a return on investment, or so what's the financial plan and those kinds of things, how to incorporate that, I think, becomes critical. And I think we need to learn more about how to do that.
I completely agree. I just had that privilege of finishing a research project for the Commonwealth, interviewing people around the country about how they're making the value case for complex care. And what emerged out of that, definitely, no matter where you sit in the system, you need to be able to articulate the cost benefit and utilization benefit, but also patient family defined quality measures in addition to evidence-based disease management quality measures. And then the patient, provider, partner satisfaction, and then the impact on equity. So how do things that really contribute to equity, like access to care, access to insurance, housing, safety, food security, and then how can you look at that as a combined return on investment equation? Across the board, people leading organizations want to be looking at that fully and really starting to incorporate that. But we have a great need for more rigorous measures in those quadrants.
Great discussion. Nice setup for our first panel discussion, and then the rest of today as well. We're about 7 minutes or so before we start. We're starting at 8 o'clock Pacific time, 11 o'clock Eastern time for the panel. We have many of the panelists have joined us. We have a few more we're waiting for, so we wouldn't want to start before the full panel is convened. So we have really about 5 minutes. I think what we'll do is we'll just take a brief break. We'll all remain on, but just to mute ourselves and potentially go off video for a minute, but we'll all be back on at 8 o'clock and start the first panel. So thank you for your patience. We'll be right back.
Produced by the U.S. Department of Health and Human Services.